Imagine this for a moment. You're active, maybe really dedicated to a sport, perhaps football, running, dance, whatever it is. Or maybe you just love being active.
Mm-hmm.
And then this ache starts deep in your hip, maybe your groin. Not from a specific injury, it just creeps up. Sometimes it's sharp, especially after activity or even just sitting for a while.
It's a very common story, unfortunately.
And you live with it for months, maybe years, adjusting how you move, hoping it'll go away, but it often doesn't. Well, that nagging pain, that mechanical niggle, might be femoroacetabular impingement, or FAI.
Indeed.
It affects a huge number of symptomatic athletes, maybe 55%, but it's also present, often silently, in about 10–15% of the general adult population. Today, we're diving deep into FAI. I'm your host, here to navigate through the complex details, and I'm joined by our expert guest. He has this fantastic ability to take really complex medical information, see the patterns, and explain it all in a way that makes sense.
It's great to be here. The hip joint really is an incredible structure, designed for both power and subtle movement. But yeah, even small changes in its shape can cause significant problems like FAI.
Absolutely. And that's our mission today, to really get under the skin of femoroacetabular impingement. We'll look at what it is, the different types, who gets it, why they get it, and crucially, how it's diagnosed and what the latest treatment options look like, from physio right through to surgery, and what it all means for long-term hip health. So let's get stuck in. Okay, let's start right at the beginning. Femoroacetabular impingement, FAI. What exactly is it? It doesn't sound like a typical disease, does it? More like a physical fit issue.
That's a very good way to put it, actually. It's not a disease like an infection. It's what we call a pathomechanical process.
It's pathomechanical, right?
Yeah, think of your hip as a near-perfect ball and socket joint. You have the femoral head, the ball at the top of your thigh bone, fitting snugly into the acetabulum, which is the socket in your pelvis. Normally, they glide smoothly. In FAI, that smooth gliding is disrupted. You get abnormal contact, basically. The femur and the acetabulum repeatedly collide or rub against each other incorrectly during movement.
A collision.
Exactly, a mechanical collision. And this isn't gentle. It's often a forceful pinching or grinding. Over time, this constant abnormal contact starts to cause damage.
Damage to what, specifically?
Well, typically the first structure to suffer is the labrum. That's a ring of strong fiber cartilage around the rim of the socket.
Right.
Think of it like a gasket or a seal.
Okay.
The rubbing damages it, causes tears. Then the articular cartilage, that incredibly smooth white lining on the bone surfaces that lets them glide, that gets injured too.
Right, the slippery stuff.
Precisely. And this ongoing damage, this mechanical insult, is what leads to the progressive hip pain and stiffness that people experience. So yes, fundamentally it's a problem of shape and mechanics.
That makes sense. And you mentioned different types, that this extra bone or abnormal shape shows up in distinct ways.
That's right. Although the underlying issue is this abnormal bone shape causing the collision, where that abnormality is located defines the type and often correlates with who tends to get it. We generally talk about two main types, though very often people have a mix of both.
Okay.
The first is cam impingement. The name comes from engineering, like a camshaft that isn't perfectly round.
Ah, okay.
This is a femoral-based disorder. The problem is on the ball side, the femur. We tend to see this more in young athletic males.
Young men, okay.
Yes. Essentially, the femoral head, or usually the junction between the head and the neck, isn't perfectly spherical. It's a bit aspherical or too broad, often with a characteristic bump on the front outer side.
A bump on the ball.
Exactly. We're talking about a decreased head-to-neck ratio or offset. Basically, the smooth contour is lost. Now, imagine this non-spherical ball trying to move fully within the socket.
It's going to jam, isn't it?
Precisely. As a hip flexes and rotates inwards, that bump, the cam lesion, effectively levers against the rim of the socket. This creates a shearing force right where the cartilage meets the labrum.
Ouch.
Yes. Instead of gliding, it peels the cartilage away from the bone. That's cartilage delamination, and it can tear the labrum, causing labral separation. On x-rays, you might see what's called a pistol grip deformity because of the shape.
Pistol grip. Got it. So that's cam. What's the other type?
The second type is Pincer impingement. This is an acetabular-based disorder. The issue lies with the socket, the acetabulum.
So the socket's the problem this time.
Correct. We tend to see this more frequently in active middle-aged women. Here, the socket rim has too much coverage, an overhang, usually at the front and top part.
Too much socket.
In effect, yes. It might be because the socket itself is angled slightly backwards, it's acetabular retroversion, or it might be just generally too deep, what we call acetabular protrusio or coxa profunda.
Okay.
So with Pincer, when the hip flexes, instead of the bump shearing things, The overhanging rim of the socket directly pinches or crushes the labrum against the femoral neck.
Crushing the seal.
Exactly. This often causes tearing within the substance of the labrum itself. And interestingly, you can get what's called a contracoup cartilage injury.
Contracoup, like in head injuries.
Similar principle. As the front of the neck hits the overhanging socket rim, it levers the back of the femoral head against the back wall of the socket, damaging the cartilage there, opposite the main impingement site.
Wow, okay. Any specific signs on X-ray for Pincer?
A classic one, especially with retroversion, is the crossover sign on a pelvis X-ray, where the front and back walls of the socket seem to cross over.
Right, cam and Pincer. But you said people often have both.
Yes, absolutely. It's really important to stress that. Combined impingement, a mix of both cam and Pincer features, is actually the most common scenario we see in symptomatic patients, perhaps up to 80% of cases. So often, we need to address both aspects surgically.
Okay, that's clear. These aren't just minor anatomical quirks then, they cause real mechanical problems. And it sounds like this isn't just about the immediate pain of that collision. It sets off a kind of chain reaction, doesn't it? Leading to bigger problems down the line.
Precisely. That's the critical thing to understand about the long-term picture. The immediate pain is from the pinching and rubbing, yes. But it's the chronic, repetitive nature of that mechanical collision that does the real damage over time.
Right.
This constant friction, whether it's shearing from a cam lesion or crushing from a pincer, leads to progressive labral degeneration and tears. The labrum just isn't designed to withstand that kind of abuse, so it wears down, frays, tears.
And the cartilage, too.
And the cartilage, too. That smooth gliding surface suffers significant cartilage damage. It might soften, fray, develop blisters, or even full-thickness tears or flaps. And the trouble with articular cartilage is its very limited ability to heal itself.
It doesn't repair well.
Not really, no. So over time, this relentless wear and tear transforms localized damage into broader joint degeneration, which is why FAI is now recognized as a major known risk factor for the development of osteoarthritis of the hip.
Ah, so it leads to arthritis earlier.
It certainly seems to accelerate the process, yes, leading to hip dysfunction and potentially the need for hip replacement surgery much earlier in life than we might otherwise expect. It's a pathway from subtle shape difference to significant joint failure, potentially.
That's quite sobering. So if these bone shapes are the root cause, what causes them? Is it something you're born with? Is it genetics? Or does activity play a role?
Yeah.
You mentioned athletes.
It's a really key question, and the honest answer is we're still figuring out all the details, but the current thinking points towards a combination of factors. It's rarely just one thing.
Okay.
Firstly, there does seem to be a genetic predisposition. Research suggests genetic factors may contribute. Specific small variations in our DNA, things called SNPs, single nucleotide polymorphisms, tiny genetic differences. Some, like variants in genes called GDF5, FRZB, DIO2, HOX9, have been linked to particular hip shapes, both on the femur and socket side, and also to an increased risk of developing osteoarthritis.
So your genes can literally shape your hip in a way that makes FAI more likely.
It seems that way, yes. It sets the stage, potentially.
Interesting. And the athlete connection, does playing sport cause it?
That's the athlete paradox, as you called it. We definitely see more FAI, particularly the CAM type, in athletes. But, and this is really crucial, exercise does not cause FAI in a normal hip.
Okay, that's important.
Yes. The leading theory is that during adolescence, when the bones are still growing and developing, the increased stress along the growth plate of a hip from high-intensity sports, think repetitive deep flexion rotation like in football, hockey, martial arts, might trigger a sort of stress reaction.
The bone reacts to the stress?
Yeah. Exactly. An increased stress reaction bone formation. The body adapts by laying down more bone. But in this area, it can result in that cam deformity, that bump. So intense activity during those key growth years in someone perhaps already predisposed might lead to the shape forming.
So activity doesn't cause it from scratch, but it can contribute to the shape developing, or at least make an existing shape symptomatic earlier.
Precisely. If you already have that subtle anatomical difference, vigorous activity involving lots of hip movement will provoke the impingement more often and more forcefully, leading to symptoms sooner. It unmasks the problem.
Right. Are there other factors? Childhood conditions?
Yes, definitely. Childhood influences are important. A history of slipped capital femoral epiphysis, or SCFE, is a major one. That's where the ball part slips off the thigh bone at the growth plate during childhood. Even after it's fixed surgically, the residual shape change, the deformity, can directly cause impingement later in life. Other conditions like Perthes disease, which affects blood supply to the hip in childhood, and hip dysplasia, where the socket is too shallow, are also linked to a higher chance of developing FAI.
Yeah.
So it's often multifactorial. Genetics, developmental stress, maybe previous hip issues.
Okay, that makes sense. But then if these shapes are actually quite common, as you said earlier, why do some people have terrible symptoms while others with the same X-ray findings feel absolutely fine? It's confusing.
It is confusing, and it's a huge area of research. You're right, the prevalence of the bone shapes is surprisingly high. We mentioned 10–15% in the general population having the morphology. But remember that study, the meta-analysis by Frank et al.? They found cam deformity in 37% and pincer deformity in a massive 67% of asymptomatic volunteers. People with no hip pain at all.
67%. Wow.
Exactly. So a huge number of people are walking around with these FAI bone shapes without any symptoms. The morphology itself doesn't automatically equal pain. We also see those gender differences in prevalence, cam more in men, pincer more in women. But again, many are asymptomatic.
So what's the tipping point? Why do symptoms start for some people?
The general consensus is that symptoms develop when the mechanical collision finally starts causing significant damage to the cartilage or the labrum. It's when those soft tissues, which have nerve endings, start to break down under the repetitive strain.
So it's the damage, not just the shape.
Exactly. The onset of pain, clecking, stiffness that usually signals that the pathological process is now actively injuring the joint structures. And once that happens, if the impingement continues, the condition is likely to worsen. The damage progresses. Having the shape is one thing. Having symptoms means the joint is now suffering.
Right. Which brings us neatly to diagnosis. For someone with that nagging hip or groin pain, what are the telltale signs? How do doctors start to suspect FAI specifically, given hip pain can be so vague?
It can be very vague, you're right. That's why a careful history and a thorough physical exam are absolutely paramount.
What do patients typically report?
Usually a gradual onset of hip pain. It's often not a sudden thing. The location is most commonly deep in the groin area, but as we said, it can radiate to the thigh, buttock, outer hip, even the back.
The C sign?
Yes. Often they'll use that characteristic C sign, cupping their hand around the side in front of the hip to show where it hurts. That's quite suggestive of something inside the joint.
Okay. And what makes it worse?
Classically, pain is exacerbated by hip flexion and internal rotation. So activities involving those movements, high-intensity sports, squatting, getting in and out of cars, driving, even just sitting for prolonged periods.
Makes sense. That position forces the joint together.
Exactly.
Yeah.
They might also report mechanical hip symptoms, things like clicking, catching, locking, or a popping sensation. That strongly suggests a labral tear is involved.
And during the physical exam, what are you looking for?
We look for restricted movement. Often there's limited hip flexion and particularly limited internal rotation, especially when the hip is flexed to 90 degrees. Sometimes internal rotation is less than 5 degrees.
Wow, very restricted.
Yes. And the key provocative test is the anterior impingement test, or FEIR test. We gently flex the hip to 90 degrees, bring it across the body slightly, adduction, and then rotate it inwards.
And if that hurts?
If that reproduces their specific pain, it's a positive test. It's highly sensitive, positive in about 88% of patients with FAI. It really hones in on that specific conflict zone.
Okay. So history and exam give a strong suspicion. Then comes imaging, presumably, to confirm it and see the extent of the problem.
Absolutely. Imaging is essential to confirm the bony shapes and, critically, to assess the state of the labrum and cartilage. It completes the picture and guides treatment.
What imaging do you start with?
We always begin with radiographs, standard x-rays. A specific set of views is needed, a standing AP pelvis view, an AP view of the affected hip, and a good lateral view of the hip.
What do these show?
They allow us to assess the bone structure, looking for those cam and pincer lesions. We look for the pistol grip deformity for cam, signs of overcoverage like the crossover sign for pincer, or maybe a deep socket protrusio.
And you measure things on the x-rays?
Yes, precise measurements are key. The alpha angle, usually measured on a special lateral view like a Dunn or frog leg view, quantifies the cam deformity. An angle over 50–55 degrees is generally considered abnormal. We also measure acetabular coverage with things like the lateral center edge angle. An angle below 25 degrees might suggest dysplasia, not enough coverage, which is different from FAI's overcoverage. Different views, like the done view, are best for seeing the cam lesion, while a false profile view helps assess coverage at the front.
So X-rays give the bony blueprint. What about CT scans?
CT scans can be a useful adjunct. They give incredibly detailed views of the structural abnormalities and allow for amazing 3D reconstructions. These are fantastic for preoperative planning, letting the surgeon really visualize the shape and plan the bone resection. The downside is the higher radiation dose.
Right. And for the soft tissues, the labrum and cartilage.
For that, MRI is the gold standard. Specifically, MR arthrography is often preferred.
Arthrography, that involves an injection, doesn't it?
Yes, exactly. An intra-articular contrast injection, a special dye, is put into the hip joint just before the MRI scan. This dye leaks into any tears or defects in the labrum or cartilage, making them show up much more clearly. It's the best modality to evaluate for articular cartilage and labral damage.
It makes sense.
MRI also shows the bone shape well, without radiation, and it's excellent for ruling out other causes of hip pain that might mimic FAI, like a vascular necrosis, stress fractures, or various types of tendinitis.
So MRI is really comprehensive. Is there anything else diagnostically?
One other tool is a diagnostic intra-articular injection of local anesthetic. We numb the hip joint directly. If the patient's pain significantly improves, even temporarily, it strongly confirms the pain is coming from inside the joint, likely the FAI. It can be very helpful when the picture isn't perfectly clear.
That's a really thorough diagnostic process. So once FAI is confirmed, surgery isn't automatically the next step, is it? What about conservative approaches?
No, absolutely not. Non-surgical management is always the first port of call, especially for patients who are minimally symptomatic or don't have those definite mechanical symptoms like locking.
What does that involve?
It's usually a combination approach.
Mm-hmm.
Firstly, activity modification. This means identifying and reducing or temporarily stopping activities that provoke the pain. Not stopping everything, but being smarter about movement.
Avoiding the triggers.
Exactly. Secondly, and crucially, targeted physical therapy. A good physio will assess movement patterns, look for weaknesses or imbalances in the kinetic chain, and work on improving hip range of motion and strengthening the surrounding muscles, glutes, core muscles.
To support the joint better.
Precisely. Better control, better mechanics can sometimes reduce the stress on the impingement zone. Thirdly, pain management, mainly with NSAIDs, non-steroidal anti-inflammatory drugs, to reduce pain and inflammation.
Like ibuprofen.
Yes. And as we mentioned, that intra-articular injection of local anesthetic and steroid can be used therapeutically too. The steroid reduces inflammation inside the joint, providing pain relief that can last weeks or months, making physio more effective.
But these don't fix the underlying shape, do they?
No, and that's the critical limitation. Conservative measures manage the symptoms, they manage the inflammation, they might improve mechanics around the problem, but they don't change the bone shape. They don't stop the collision happening.
So if these don't provide lasting relief,
then surgery becomes the next consideration. If symptoms persist despite a good trial of conservative management, usually 3 to 6 months, or if mechanical symptoms are prominent, then we discuss addressing the underlying anatomy directly.
Right. So tell us about the surgical options. What's the aim?
The aim of surgery is to reshape the bones, the femur, the acetabulum, or both, to eliminate the abnormal contact, the impingement. Basically, to restore normal hip mechanics and allow smooth, pain-free movement. There are two main approaches. The most common approach now is arthroscopic osteoplasty. This is minimally invasive, done through small keyhole incisions using a camera, the arthroscope, and specialized instruments.
Keyhole surgery for the hip.
Exactly. The surgeon can see inside the joint on a screen and precisely trim the bony rim of the acetabulum, if it's a pincer lesion, or shave down the bump on the femoral head or neck for a cam lesion. That's the osteoplasty part, reshaping the bone.
And they can fix the labrum at the same time?
Yes, a huge advantage is that arthroscopy allows the surgeon to thoroughly assess and repair or clean out any damage to the labrum and articular cartilage as well. Studies show it gives equivalent results to open hip surgery, but often with a quicker return to activity.
That sounds promising. What's the open surgery option?
The alternative is open surgical hip dislocation. This is the previous gold standard. It involves a larger incision and a technique where part of the hip bone, the greater trochanter, is temporarily detached to allow the surgeon to safely dislocate the hip joint and get a wide, direct view of the femoral head and socket.
Sounds quite major.
It is a bigger operation, yes, but it's designed very carefully to preserve the blood supply to the femoral head, so the risk of a vascular necrosis, or AVN, is very low. It provides excellent exposure, which can be really useful for significant femoral deformity or complex cases. Return-to-play rates for athletes after open surgery are historically very high, over 85–90%, provided they don't already have significant arthritis.
Okay, and regardless of the approach, dealing with the labrum is key, you said.
Absolutely critical. If there's a labral tear, which there usually is in symptomatic FAI, it needs to be addressed, repaired, or sometimes reconstructed at the same time as the bone is reshaped. Just cleaning out the labral tear, isolated labral debridement, without fixing the underlying bony impingement simply doesn't work long term.
Because the cause is still there?
Exactly. It's a
Fine.
major cause of treatment failures. You have to address both the bone shape and the soft tissue damage it's caused.
Right. Are there other surgeries sometimes needed alongside?
Occasionally, yes. If there's significant hip dysplasia or acetabular retroversion, a more complex operation called a periacetabular osteotomy might be needed to reorient the socket. And if the joint is already badly worn out with end-stage arthritis, then hip arthroplasty, a total hip replacement, becomes the necessary solution. It really depends on the individual case.
Okay. Now, surgery always carries risks. What are the potential complications people should be aware of with FAI surgery? And what's a realistic long-term outlook?
That's a crucial conversation to have with patients. While generally safe and effective, complications can occur.
What are the main ones?
Major, though thankfully rare, complications include things like femoral neck fracture, particularly during the bone reshaping for a cam lesion. Surgeons are very careful to limit how much bone they remove, generally less than 30% of the femoral neck diameter, to minimize this risk. With arthroscopy, very rare risks include things like abdominal compartment syndrome from fluid leaking where it shouldn't, or nerve injury. Other potential major issues, though uncommon, are blood clots, DVTPE, deep infection, or dislocation after surgery. A vascular necrosis is a risk, though minimized by careful technique.
And minor complications.
These are more common but usually manageable. Things like heterotopic ossification, where extra bone forms in the soft tissues afterwards. We often give NSAIDs like indomethacin postoperatively to help prevent this. Temporary nerve irritation or praxeus, causing numbness, maybe in the thigh or perineal area from traction during arthroscopy, can happen but usually resolves. Superficial infection or bruising are also possible.
Okay, and the long-term prognosis. Does surgery stop arthritis?
That's the million-dollar question, isn't it? We know the natural history of untreated FAI likely leads to early-onset hip dysfunction and arthritis. Surgery definitely aims to change that course. It's very successful at reducing symptoms and improving function in the short to medium term, and it can prevent future damage by stopping the impingement. But the current scientific evidence is still unclear whether it will definitively delay or prevent the development of hip arthritis in the very long run, say 15–20 years or more.
So it might still happen later.
It might. Patients need to understand that while surgery aims for joint preservation and symptom relief, they may still develop arthritis in the future and potentially need a hip replacement eventually. The goal is to push that possibility as far down the road as possible or lessen its severity.
That's important expectation setting. And after surgery, rehab is vital, I imagine.
Absolutely essential.
Yeah.
Post-operative rehabilitation is just as important as the surgery itself. It's a structured, progressive process guided by physical therapists.
What does it involve?
It starts with a period of protected weight bearing, using crutches for maybe 2 to 6 weeks, depending on the surgery. Early passive range of motion starts almost immediately to stop stiffness. Then comes active range of motion, followed by intensive strengthening exercises for the hip and core, and gait training to normalize walking.
And getting back to sport.
That comes later, usually after 12 weeks or so, with gradual reintroduction of jogging, jumping, and agility exercises. It's a careful progression, tailored to the individual. The physio's role is absolutely critical in guiding this safely.
It sounds like a long process.
It requires patience and commitment, definitely.
Finally, looking ahead, what's new in the world of FAI? Where is the research heading?
It's a very active field. The number of scientific publications on FAI has exploded in the last 15–20 years. We're seeing advancements like computer-based navigation systems being developed to help surgeons perform the bone resection even more accurately during arthroscopy.
Improving precision.
Exactly. But there's also an acknowledged need for more high-quality research. We need more mechanistic studies to really understand why the damage occurs at a cellular level. And critically, we need more long-term outcome data studies following patients for many, many years to truly understand the natural course of FAI and the real long-term impact of non-surgical and surgical treatment on preventing arthritis.
So, still learning.
Always learning, yes, but we've come a very long way in understanding and treating it effectively.
This has been incredibly informative. It really drives home how complex hip pain can be, stemming from these underlying mechanical issues. Just to summarize the key takeaways for everyone listening. Firstly, FAI isn't just pain, it's a mechanical clash in the hip caused by abnormal bone shapes, cam, pincer, or usually combined. Bone hitting bone where it shouldn't. Secondly, it's a clear risk factor for developing early hip osteoarthritis, especially in active people whose movements can accelerate the wear and tear.
Correct.
Thirdly, diagnosis hinges on specific clinical tests, like that F8R impingement test, combined with imaging x-rays for the bone shapes, MRI, often with dye to see the labrum and cartilage damage.
Yes.
Fourth, treatment starts conservatively with activity changes and physio, but precise surgery, often keyhole arthroscopy, can reshape the bones and repair soft tissues to fix the mechanical problem.
That's the pathway.
And finally, while surgery is good for symptoms and function now and can prevent further immediate damage, its ability to completely stop arthritis developing decades later is still being studied. It's about long-term joint preservation.
Well summarized.
If you found this deep dive helpful, we'd really appreciate it if you could take a second to rate the show or share it with someone who might find it useful, maybe someone you know dealing with persistent hip issues. And a final thought to leave you with. Just consider how these seemingly small variations in our anatomy, things we might not even know we have, can have such a huge impact on our movement, our quality of life, and our long-term joint health. It really highlights the importance of listening to our bodies and seeking answers when things don't feel right.